I'm Christan Bury. I want to thank Baxter for inviting me to be here, but all of the content on these slides were developed by me. We're going to focus on the second objective at this point in the lecture, recognize the importance of appropriate protein dosing to improve outcomes among acute critically ill patients receiving nutrition support. So I know there's many dietitians in the audience, but I know that there are some physicians and pharmacists. You obviously care about nutrition, but I briefly want to talk about why we should really care about inflammation, this acute critical illness, and what actually is happening to our patients. During the inflammatory response, a cascade of clinical and biochemical events starts as soon as 24 hours from the onset of illness. And this could be something from a trauma or even a planned surgery. Even if we know our body is about to undergo a surgery, it still doesn't like it and it will react. This response is led by pro-inflammatory cytokines, which are the chief stimulators for regulating acute phase protein and promoting muscle catabolism and inhibiting muscle protein synthesis and repair. So this is what increases our resting energy expenditure, and we need to mobilize amino acids to be able to have fuel substrate utilization. And this, of course, causes issues like anorexia, somnolence, and this vicious cycle that these patients get stuck in. And you can only imagine that if a patient is malnourished pre-existing, it's almost like they don't stand a chance. So it's very important to initiate nutrition support early, because up to 15 to 20% of our total body protein is metabolized in the first 2 weeks following a trauma or illness. And metabolism during sepsis or trauma, any complications post-op or in the acute critical period, can increase our basal energy expenditure. And we know that malnourished patients have less reserve and an altered fuel utilization during this time. I'll admit this data was published before I was born, but it's essential. It shows that we cannot pick where we burn calories from. Let's see, on your left, you have your resting metabolic rate and how it's increased extensively, of course, for a major burn. Even a planned surgery, your resting energy expenditure is much higher up to 20 days out. And that's when things go well. That's when it goes the expected post-op course that we want for all of our patients, and we know that that's not happening. On your right, we see the nitrogen excretion, and we see the increased protein demand for patients undergoing these issues. So I just think it's so important, especially for these populations that you may think that they have reserve, our obese patients, but could be effectively sarcopenic underneath. And we really need to advocate for them, because we can't pick where we burn calories from in this stress state. Briefly, I'm going to talk about malnutrition diagnoses. It's been wonderful being here and collaborating with two awesome women from Canada and Australia, and I'm bringing in my American influence, and we talk about the different guidelines. We all just want the same thing, and I think we're all doing very similar things. We are using the ASPEN guidelines to diagnose malnutrition. As a dietitian, we're doing physical exams head to toe and looking for muscle and fat wasting. We're using characteristics like weight, weight loss prior, intakes prior, and functional capacity to create a diagnosis. And of course, the GLIM, we're incorporating that as well, which is I think quite similar. At the heart of it, you are understanding the etiologic and phenotypic criteria and trying to evaluate. All this to say, everyone's trying to do the best they can to figure out the patients we need to focus our energy on. I want to highlight a little bit what we're doing at the Cleveland Clinic. We could have a whole talk, and I've been so inspired listening to people here doing body composition lectures. I think that this is where there's a space for patients that you can't see. Of course, we see the cachectic BMI 18, woman who falls and breaks her hip. We care about her nutrition. We should be caring about the people that you can't see underneath, that they're wasting away in front of us, and then they're so weak when they leave us. So, of course, novel assessments using bedside ultrasound to assess the changes. Of course, there's a long way to go, but we can at least evaluate the size, possibly the quality, and the changes over time. Also, CT analysis. Here's an example of a patient of ours, a 71-year-old male. His BMI was 30, so he's obese. And no one maybe is in a rush to feed him, but if we have an available abdominal CT, we're able to segment out. And the green is the visceral fat, the blue is the subcutaneous fat, and the yellow is his muscle at L3. And we can see, we can calculate a skeletal muscle index, which correlates to different levels of sarcopenia. We see this patient is sarcopenic. But we wouldn't know that on his physical. His physical exam that we performed, we found no malnutrition. So I think it's very important If I may bring up an analogy, because I'm on day 4 of my 5 kids at home and I'm almost starting to miss them, it's kind of like it's kind of like parenting or anything where you treat everyone equally, but it's not the same. So our patients, we treat them equally. We want to feed them, we want to give them world-class care, evidence-based, and we care about all of our patients. But I do think that there are some patients that deserve a lot more of our energy and advocacy and assertiveness. You know, those patients where you circle back on rounds, you bug that attending one more time. Have you thought about nutrition? And it's these patients where they might be not malnourished to someone that's not one of us or trained and cared about nutrition. So I just feel such a passion for figuring out where to focus our energy and then how we do implement those practices. So of course we know that the preferred route is the enteral route. But I'm finding in my practice it can be difficult to meet the protein needs and to feed them enterally. Of course, in a surgical ICU, when the bowel's been manipulated, when you have an element of malabsorption, and I'm quite finding that I'm using supplemental parenteral nutrition within the guidelines, which we'll talk about. I'm using it a lot more to meet the high protein demand in a specific way where we can feed the patients high protein, but not overshooting the calorie demand that Leah was mentioning, that specific point in individualized nutrition. So in patients that are low risk, we can consider, the guidelines suggest we should consider supplemental PN day 7 to 10 if we're unable to meet our energy needs at least 60% by EN alone. But I offer you to just think about the trajectory of an ICU patient. It's not often that they come to us fresh day 1. At least at our institution, sometimes they've waited at home to get care, or they've gone to a facility, a rural facility, and then be transferred up. So I think that that's why dietitians are so great at investigating, where are you at in your journey? Were you at an LTAC before? Oh, you were just here last week, and then you came back in with an ileus. So we're very good at being detectives and talking to family. We have the time to do that as opposed to some of our physicians. So just really highlighting that just because they come to you day 1 does not mean it's day 1 for them in their journey. Patients who are high risk and severe malnutrition, we should be starting supplemental parenteral support as soon as possible following your ICU admission when we're not able to use the gut or reach goal. Of course, we should note that no parenteral support or supplemental PN should be used in severe sepsis or septic shock. So when we are using parenteral support, either supplementally or on its own, this sort of highlights what Lee was talking about, and I have a graphic on it too about this lower calorie, non-protein calories early on in the critical illness, but meeting the protein needs. And this way of using parenteral support has been shown to decrease infectious morbidity, hospital length of stay, and hyperglycemia. As a clinician, we should gradually increase our parenteral support to full dextrose calories as the patient stabilizes. And of course, follow them over time because things change in an instant, and we want to be part of that in their plan of care. So just quickly looking at the recommendations from ASPEN and where it comes from, we have this prospective observational study by Weiss determined that 1.3 grams of protein per kilo and energy targets was associated with a 50% decrease in 28-day mortality, whereas this decrease was not seen when you met energy targets with low protein. So observational, but it's what we have to build upon. Here's another one. Prospective observational from Allingstrup with a mixed med-surg stepwise and we see a stepwise decrease in 28-day mortality with an increase in protein provision. So here is just a quick graph of how we do have metabolic card at our institution. Regretfully, we're not able to do it probably at the extent that my wonderful colleagues are, just because of our size. So there are a plethora of predictive equations that we are using, often weight-based equations, and this has been so interesting being here with so many people from around the world. I was laughing out loud at the wonderful talk with the subgroup of AKI from the EFFORT trial, and someone had asked about BMI, and they said, we tried to find BMI 30, we can't find those patients in China. So I think it just shows that we all are sort of trying to combine our practices within what we're working with, and I can tell you, I have a lot of patients with this, with a high BMI, so we're using sort of this lower calorie range of their actual weight, but using either their usual weight and adjusting that protein dose or using an ideal body weight, and of course following up quite frequently. I do think it's important, just some special considerations in critically ill, because it's not like critical illness is its own, there's so many subsets of it, and we feed these patients quite differently: surgical, medical, cardiovascular. So first, AKI, and I do go in depth on what we've learned just at this conference about AKI, so stay tuned. But the guidelines suggest that in renal failure, we could give 1.2 to 2 grams of protein per kilo. And also, if we've started dialysis or continuous renal replacement therapy, we can maybe go upwards of 2 to 2.5 grams of protein. This is a quote from a nephrologist that I work with. I connect a lot with them because you really want to protect the kidneys, and I wanted to get his input. This is just an anecdotal quote that, the nephrology, they're always saying, reduce the protein, but I think you have to think where they are. Are we going to start dialysis? Are we weaning from it? So his perspective was, if someone cannot tolerate nutrition given their current circumstances, we should not withhold nutrition just to prevent dialysis. We need to support their healing. And I want to point, it's very rare that just the kidneys are failing, just the kidneys, right? I mean, it happens, but often kidney failure comes along with all of your other organs failing as well. So I think it's important to look at the full picture, and we care about every organ. But that's why I also think dietitians are great because we look at kind of the whole picture and care about all of the organs at the surface. For hepatic failure, we would like to feed 1.2 to 2 grams of protein per kilo and get a dry weight if we can. If a patient has an open abdomen, we're feeding quite high to meet those losses from the wound. TBI and burns have fairly similar rates of protein, 1.5 to 2.5 grams of protein per kilo, and for burns, 1.5 to 2. I'll admit we're not a burn center, but these are the recommendations per ASPEN. If the patient is septic, we're feeding that high range of protein but very low calories in that initial phase of sepsis while they're acutely ill. And I think that I hope to focus on this chronically critically ill, these patients that have been in your ICU 3 weeks, months, and you're just not sure how to continually feed them to meet their demand. Monitoring and evaluating our patients, especially the obese patients or ones that are difficult to do the physicals on, I think that this is where the space for lean body mass assessment tissue, looking for changes, looking for quality. Also, urea creatinine ratio is showing to be something exciting in the future to look at in respect to muscle catabolism. But I also just offer looking at the whole picture and how are they doing? Are they weaning from the vent? Are they having longer days, on trach collar? Are they getting up longer with physical therapy each day? So all of these play into and I know those are hard to quite measure, but putting the whole piece together with the objectivity that we do have. So just looking at, once the guidelines have been published, each kind of year in review with protein. So the next few slides will be major protein studies through the year. So this was a retrospective data collected from days 0 to 7 in ICU, and this kind of shows they had 3 protein categories: a less than 0.8 grams per kilo, 0.8 to 1.2, and upwards of 1.2 grams of protein per kilo. And the results showed that low protein before day 3 and high protein after day 3 was associated with the lower 6-month mortality compared to overall high protein. And we see increasing protein on days 3 to 5 to 0.8 to 1.2 and upwards of 1.2 grams of protein beyond day 5 is associated with the lowest mortality. So maybe thinking that you can't just do a prescription and walk away for a week. You really need to be following these patients closely and adjusting their prescription as we go. This was a wonderful review by Dr. Diwali. Of course, we know there are limited randomized controlled trials. It's very difficult to do blinded nutrition studies. So unfortunately, we're left with a lot of prospective observational, which I find they can still give us meaning if you have context. There was an international nutrition survey that in patients with a high malnutrition risk, every 10% increase in protein decreased the odds ratio of death and time to DC lives. So I think this is where there's this, this subset of patients that are so vulnerable that if we can get to them early and try to feed them appropriately, and of course mobilization, then they may have a chance at recovery. And in fact, there's data on quality of life where it's improved for every 25% increase in protein at 3 months. This wasn't shown at 6 months, but I still have this optimistic view that we can make a difference if we get to them early enough and are aggressive in our intervention. Then we have the updated ASPEN guidelines in 2022, which didn't really change much, but of course the evidence was still quite weak just because of the lack of randomized controlled trials. I'd be remiss if I were here and didn't talk about the EFFORT trial, which we all have been talking about, published in the spring of 2023. This was an international, single-blinded, randomized, very well-designed study where they took nutritionally high-risk adults and divided them into the high-protein group, so over 2.2 grams of protein per kilo, and a usual of 1.2 grams of protein per kilo. Their outcomes were time to discharge alive and 60-day mortality. Our results show that the incidence to DC alive was higher in the usual protein group, and the 60-day mortality was lower in the usual protein group. And of course, we learned about the subgroup where higher protein and AKI might be harmful. And I do just want to give my assessment and takeaway points of this excellent design study. If you read in the methods, they excluded patients who the clinician used their judgment where they thought low or high protein would benefit, which I appreciate, but I just want you to think about that. They excluded patients of the ones we just sort of talked about the last several slides, those vulnerable ones where they have a nuanced nutrition plan and we need to follow it closely. It just from the United States perspective, it didn't appear with the BMIs over 35 that they adjusted and used sort of a different range. So if I had a patient with a BMI of 35, I would not be feeding 2.2 grams of protein of their actual BMI of 35 weight. So maybe it was too much protein that they were prescribing in that population. Nearly half enrolled were respiratory failure, and as we know, medical patients have a different sort of beast than surgical patients and different needs. And the groups were extremely well matched, but I want to explain that over 50% had denied decrease in intakes prior to admission, over 80% did not have any chronic GI malabsorptive issues, and over 65% did not have any moderate or severe muscle wasting. And their BMIs were 28 to 29, which in the United States, that's a beautiful BMI for the ICU, which they often do quite well. So just highlighting that these weren't very high-risk nutritionally patients that they were using. Of course, the subgroup with the AKI, they had a higher rate of organ failure. As I mentioned, the kidney is rarely just failed on its own as its organ. It's usually with other organs failed as well. So it begs the question, is it really the protein that's causing the mortality? You know, correlation isn't causation, or is it the fact that the kidneys were failing, but so were the lungs, so was the gut, and so maybe that could have an impact. And their takeaways specifically that in these subgroups where high protein is necessary are in burns, trauma, surgery, and obesity. Of course, the post hoc analysis on critical patients with acute kidney injury. Again, looking at the data, 90% enrolled were medical patients, so not surgical patients who might have undergone undue stress. Higher protein was associated with a slower time to discharge alive and a higher 60-day mortality. And no subgroup suggested the benefit of higher protein. But I think it was really great how they highlighted about renal replacement therapy or kidney replacement therapy here. The protein dose, it was not associated with the incidence of AKI. So the key takeaways, to me is once there's AKI, if we're not going to dialyze, we should scale back on protein and be modest and follow that plan and preserve that organ to not push them to dialysis. However, if the plan medically is to start dialysis, we need to meet that high protein need and follow them while they're on renal replacement therapy. I think it was exciting to see that the higher protein didn't cause the need to start renal replacement therapy. So I think it's just so exciting. The kidney is such a complex organ and more to come for that. But I do think that is an area where if they're not going to dialyze, we shouldn't just be, I sound like I'm barreling forward ahead with protein, and mostly I am, but that's a population where I would scale back for sure and see how that patient can recover that kidney function. So here in 2024, we have the effects of higher versus lower protein, meta-analysis of randomized controlled trials. This was over 23 randomized controlled trials with protein delivery, overall showing that higher protein was not associated with overall mortality, and higher protein with early physical rehab trended toward improvement of quality of life and functional measurement. And I just think that that's something aspiring to be. You talk about we've improved critical illness survival, but these patients don't have a good quality of life, especially, COVID isn't over, but the patients that have come back in and have been so debilitated, they're not going back to their lives. They're not going back to their grandchildren. So I think that this is where we can maybe hopefully make a difference of feeding early, high protein, lower calorie in the early acute phase, get them up and moving, and try to preserve that function to get them back to where they want to be. And of course, watching forward for this AKI subgroup and being mindful of the kidney. So to me personally, to restrict or not to restrict protein, I do restrict when the kidneys are the only organ system failing, when they have AKI and we're not going to dialyze. Maybe the chronically critically ill, where we're wanting to see if their kidneys are going to recover. We've weaned them from CRRT, they're on IHD, and maybe we can give them a chance to be able to be off dialysis entirely. And in renal transplants, I'm definitely being quite modest in protein, but I will not restrict protein with multi-system organ failure, continuous renal replacement therapy, patients with an open abdomen or large abdominal outputs from drains, fistulas, or wounds, and of course trauma, burns, and surgical patients. So for the future, maybe there's a role for intermittent feeding of protein, especially optimizing the protein that we're giving, either the gut or parenterally, and topping off with IV protein. Emphasis on early mobility, because we can't really build amino acids without contracting those muscles. Just keeping in mind the persistent hypermetabolism in these long-term critically ill patients and trying to meet their demand, and just trying to elevate our own practices, dietitians, with evolving tools, body composition, CT, and ultrasound. So I thank you so much for listening to me.